Today, we are thrilled to welcome Dr. Chacko to the show. Dr. Chacko is an intensive care physician practicing in Bangalore with a rich background that includes high acuity work in top institutions like Manipal Hospital and Narayana Health. He has also brought in experience overseas, having served as an ICU physician in NHS in UK and Royal Adelaide and Royal Darwin Hospitals in Australia. Dr. Chacko's interests extend beyond bedside. He is passionate about bedside ultrasonography and echocardiography as key tools in assessing acutely ill patients. He is diving into research, particularly meta-analysis, to explore some unanswered questions in intensive care medicine. Sir is a prolific writer. He is contributing to peer-reviewed journals and regularly blogging about some of the most pressing questions in critical care medicine. We're excited to dive in his insights, his experiences, and what he has learned along the way in this dynamic field. Dr. Chacko, we welcome you to the podcast.
Thank you, Monalisa. Thanks a lot. I'm really happy to be here. It's a great honor and pleasure to be here this evening.
Thank you for joining us, sir. So first up, how has VEXUS, that is venous excess ultrasound score, changed the way we approach fluid stewardship in the ICU? How this innovative tool is reshaping decisions around fluid management in critically ill patients, and what are its implications on outcomes, and does it have any implication on daily practice?
Yeah, it's a relatively new tool in critical care medicine to assess the degree of venous congestion. We all know about the ebb and flow of disease. In the early stage of the disease process, like in a patient with severe sepsis or trauma, we do a lot of fluid resuscitation over the first couple of days, and that may result in a lot of extra fluid in the body, might actually raise venous pressures. And as you pass on from this so-called ebb phase to the flow phase with the improved cardiac output, improved flow, then the situation arises when you may have filled too much, and there may be venous congestion in different parts of the body, different important organs of the body, and that might actually compromise perfusion to the vital organs, such as, for instance, the kidneys, where the perfusion pressure is mean arterial pressure minus the central venous pressure. And if there is venous congestion, an increase in the downstream pressure, the renal perfusion obviously will compromise. And this applies to several other organs as well. So that's an important situation which you would need to recognize early through some mechanism or some instrument, and be able to tell if your patient needs decongestive therapy to remove excess fluid, reduce the venous pressure, and improve the perfusion pressure. And it is actually based on this that the concept of de-resuscitation has actually been proposed by Manu Malbrain et al. It's a relatively new concept, maybe in the last 5-6 years or so. And they emphasize the importance of decongestion or de-resuscitation, wherein after the initial ebb phase, when you pass into the flow phase, you need to ensure that you have reduced the venous pressure sufficiently to allow forward flow in important organs such as the kidneys. And it is in this regard, with this particular fact in mind, that a ready tool by the bedside seemed appropriate. We go conventionally by the central venous pressure, which is perhaps not the most appropriate or the most precise tool in the circumstances. We do also go by the IVC diameter. In fact, many of my colleagues are totally enslaved by the IVC diameter. They are so fixated to it, to the point of exclusion of everything else. But then if you take a single parameter, it may tell you a story that's different from what's actually happening. So that's the importance of using a scale which has multiple parameters that reflect excessive venous congestion. And that's how the VEXUS score came into being. It was just introduced just a couple of years ago, 2022 it was, studied first in cardiac surgical patients to assess the degree of venous congestion and the extent of renal injury secondary to that. So what they proposed was a combination of the use of the inferior vena cava diameter, the use of the portal vein and the so-called pulsatility index, the hepatic vein, as well as the intrarenal vein. So it is a combination of all these, the IVC, the portal vein, the hepatic vein, and the intrarenal vein. And based on the findings that you see on these vessels, you come to a comprehensive score which grades the degree of congestion, starting from mild congestion to moderate to severe congestion. And it is the individual components of this score has been actually studied before, but it's the first time that these investigators came up with a comprehensive score based on all of these 4 parameters. And they studied, as I mentioned, in a cohort of postoperative cardiac surgical patients. And they found that there is an increased risk of acute kidney injury among patients with severe congestion. And the presence of at least 2 severely abnormal Doppler patterns suggested the presence of severe congestion and a higher risk of acute kidney injury. But then the question remained, does this apply only to cardiac surgical patients? Would the score apply to a general ICU population as well? And that's when Andre et al., they did a study along the same lines, using the initial VEXAS scores and subsequent scores assessed at periodic intervals. However, disappointingly, this particular study did not show that a positive fluid balance was reflected in the VEXAS score, nor did it suggest that the incidence of acute kidney injury as well as the 28-day mortality was any higher if the VEXAS scores were high compared to patients with normal VEXAS score. The findings did not suggest a statistically significant correlation. So that was a bit disappointing. But then if you look back upon this study, you will find that the number of patients who had severe congestion according to the VEXAS score was pretty small, and it may not have been large enough to really come up with a significant correlation. So in spite of the contrasting results compared to the original cardiac surgical study, it still looks like a very handy tool, which perhaps needs a little more investigation in general ICU settings to look at its efficacy in terms of predicting excessive venous congestion, reduced perfusion due to excessive venous congestion, and allow the ICU clinician to be able to resort to decongestive measures, like, for instance, the use of diuresis to allow better organ perfusion during the flow phase of resuscitation, like in a septic patient. So there are several steps with which you go through this process of VEXAS scoring, which includes, as I mentioned, 4 measurements, including the IVC, the portal vein, hepatic vein, as well as the intrarenal. And very quickly assimilate the measurement and the variability of the IVC. Hepatic portal vein is also reasonably simple to do. Hepatic veins may be a little more difficult at times, but still quite easy enough to grasp. The problem lies in the intrarenal vessels, which may be a little difficult, particularly with the swings that you see on the image with respiratory variations. So that can be a little tricky at times. So in short, it requires a good command of basic ultrasonographic skills. There may be some inter-observer variation, which might lead to contrasting results at times. As I mentioned, the intrarenal vein assessment may not be so easy. And most importantly, do not use a single parameter as your sole guiding point. Do not use VEXES alone. Go by the holistic clinical criteria. How is your patient doing as a whole? How is the hemodynamic status in terms of blood pressure? The stroke volume, if you are measuring that. In terms of peripheral edema, how does the lung sound on auscultation? Are there any B lines on ultrasonography? So you need to look at all this. Hepatic vein assessment may be limited by tricuspid regurgitation, atrial fibrillation, in which it may give you erroneous numbers. And the score itself, as I mentioned, as the evidence has also shown so far, may be more applicable to cardiac surgical patients, perhaps more than a general ICU cohort. And systemic venous congestion may not be the main factor, may not be the only factor that leads to acute kidney injury. There may be several other factors as well, like the systemic arterial pressure, for instance. The kidneys work based on the mean arterial pressure, and there is renal autoregulation. There are so many other factors which may be involved. Systemic congestion may not be the only factor, may not even be the main factor that determines renal perfusion. So you need to keep that in mind. But overall, it is one of those tools which seem to be easily performable by the bedside. You can come to a reasonable conclusion regarding the venous congestion status and perhaps resort to resuscitation measures based on what you find.
Thank you, sir. Thank you for beautifully summarizing most of the things about VEXES, what it stands for, how to practically apply it on the bedside, what is its role in the resuscitation and deresuscitation, and the evidence associated with it. Thank you so much.
Dr. Chacko, we will move to our next second question, which we go on to a different set of patients. Managing a neuro-intensive care patient for a neurological issues is always a challenge for clinicians, especially in the ICU. And with ultrasonography being utilized in each and every aspect, the challenge of managing or monitoring an ICP is always something which which affects patient care in neurosurgical patients. So, is neurosonography a viable substitute for invasive intracranial pressure monitoring?
Thanks, Jacob. You raise a very relevant question indeed, because I don't know about others, but most of the ICUs that I worked in India, the practice is not to measure invasive pressures in neurosurgical patients, as in intracranial pressure monitoring. Like, for instance, the general practice across the world in most of the advanced neurosurgical centers is to use intraparenchymal monitoring to measure ICP. And almost all patients who have severe traumatic brain injury particularly will be on ICP monitoring if they're on ventilation, sedation, paralysis, because it's very crucial to do so. There is no other clinical methodology by which you can assess their neurological well-being in patients who are sedated, paralyzed perhaps, on ventilation for an extended duration of time. And you can't do CT scans so many times. There is a limit to the number of CTs that you can do. And that's why ICP monitoring has become such an important tool in the routine monitoring of these patients. Although clinical studies have not really established the outcome benefit related to ICP monitoring, it still remains a logical tool in the monitoring of patients who are sedated, ventilated with severe, particularly traumatic brain injury in ICU. So if you do not have access to invasive pressure monitoring, as in intraparenchymal or intraventricular, what are the options do you have? One of the ready options that comes to mind is the use of ultrasonography. The use of ultrasonography to measure intracranial pressure is based on measurement of the optic nerve sheath diameter. It is based on the concept that the optic nerve sheath is a continuation of the brain itself, and it includes the meningeal layers. The optic nerve carries with it the meningeal layers as it comes out of the brain and essentially remains a part of the brain. And as the ICP rises, the optic nerve sheath also distends almost in real time, hand in hand with the rise in intracranial pressure. So, if you have bedside ultrasound, it is relatively simple to look at the optic nerve sheath through ultrasonography by the bedside, although there are several artifacts which we will briefly discuss a little later on. So if you can measure the optic nerve sheath diameter, it will perhaps be a reflection of the intracranial pressure and help you assess your patients, particularly those with severe traumatic brain injury who may be sedated, ventilated, and cannot be assessed readily. If you go by the pupillary signs, for instance, if you look for a dilated pupil, it'll be too late by the time you recognize it, and the battle would have been already lost. So that's why ultrasonography may be such a useful tool by the bedside. There are a few important points to remember when you do that. First is, of course, the use of the probe, the choice of the probe. You would use the linear high-frequency probe to look at the optic nerve sheath. And second is, how do you measure it? What is the exact location of measurement? It is 3 millimeters from the posterior wall of the globe, and you need to measure from the outermost point to the outermost point of the sheath itself. There is usually a hypoechoic artifact just around the sheath, which you should not include in your measurement. If you include that, it might still correlate, but then you will get falsely high values. So it's not really recommended to include the hypoechoic area that surrounds the sheath. And most importantly, the question also arises as to what is the cutoff for a rise in intracranial pressure. There have been several studies, all observational of course, which have looked at cutoff limits for the optic nerve sheath diameter. And people have pointed out that some of these studies have actually measured the diameter wrongly, as I pointed out, including the hypoechoic artifact around the sheath, which will make it falsely high. So there is a question about that as well. But if you measure it correctly, the cutoff is generally between 5.7 to 5.8 millimeters, 3 millimeters behind the posterior edge of the globe. So that's where you measure. Roughly 5.7 is a ballpark number that you can go by. So does this actually mean a lot in terms of raised ICP? And would you act purely based on this level of ICP? The simple answer is no, you wouldn't. You need to consider it as an indicator of raised ICP, but you shouldn't, of course, go entirely by the optic nerve sheath diameter. Obviously, you will have a look at the CT scan to see if it really confirms the rise in ICP that the optic nerve sheath diameter seems to reflect. And for that reason, it should not be taken as a single isolated number. You should look at the trend over time. A single number does not really mean very much. what I would suggest and what we also follow in our unit is to measure a baseline optic nerve sheath diameter. And you will have a CT scan, of course, to correlate with that level of sheath diameter. And then you do it periodically, once every couple of hours. It is preferable to have the same operator do it. Of course, it may not be practicable. But you go by the trend, and if at all you suspect an increase in the diameter, it would be a pointer that maybe the ICP is rising, and maybe you would get another CT scan done. So it can only be an indicator that the ICP may be rising. You would obviously require imaging as well to confirm any significant deterioration in the neurological status.
Thank you so much for highlighting the importance of ICP monitoring in neurocritically ill patients. The reluctance and the lack of expertise is always an issue. So optic nerve sheath diameter, as rightly pointed out, can be an option, at least to give the trend, and you go on the next step of evaluation. Thank you, sir.
Thanks, Jacob.
So from neuro ultrasound, we'll move to cardiac sonography, but of course from intensivist viewpoint. So how does the intensivist approach differ when using ultrasound for cardiac assessment, and what specific insights does this perspective offer in critical care settings?
A very relevant question, Monalisa. We do echocardiography by the bedside, and we are also used to our echocardiography technicians perform echocardiography by the bedside. If you look at the way they do the scans, you will be struck by the kind of meticulous measurements that they perform, including the wall thickness, precise estimation of the diameters of the chambers, precise estimation of the ejection fraction. There are so many things which perhaps the critical care physician may not look at it through a microscope, which may not be all that relevant to us. So the question remains as to what are the things that you look for most essential to assess the hemodynamic status of your patient, and what are the parameters that are of most interest to the ICU clinician. First and foremost is the question in a shocked patient is, what kind of shock is it? Is it hypovolemic shock? Severe hypovolemia is usually very easy to tell just by eyeballing the four-chamber view. You will see the chambers are small, the walls may seem to approximate with each other, particularly the left ventricular free wall might approximate the septum if the ventricle is underfilled. There will obviously be a IVC which has a lower diameter than usual, which again suggests that the patient may be hypovolemic. So just by eyeballing the echocardiography, you will get a fair degree of understanding as to whether your patient is hypovolemic or not. Volume responsiveness is a different matter altogether. And for that, you need to go a little more in detail. And what I suggest to my trainees and what I often recommend them to do is to look at the volume responsiveness by measuring the velocity time integral from the apical 5-chamber view. You start with a baseline measurement, and then you do the passive leg raise. You do the passive leg raise, wait for a minute or so, and then measure the VTI again. And if this shows a change or an increase by 12 to 15% or more, it is strongly suggestive of volume responsiveness. It is relatively simple to do by the bedside, and it applies in patients who are ventilated versus patients who are spontaneously breathing. So it gives you an overall reasonably accurate picture of volume responsiveness. You need not measure the stroke volume, which involves measurement of the the aortic diameter as well. You need not go into that detail. You just measure the VTI alone, baseline, and post-leg raise, and see if there is an increment in the velocity time integral, which suggests volume responsiveness. So VTI alone would do, and the respiratory swing on the VTI waveform would also be a strong, powerful indicator of volume responsiveness in patients who do not have spontaneous respiratory efforts. So that applies only to patients who don't have spontaneous breathing. The VTI variation with respiration, like with other respiratory parameters. But, as I mentioned, VTI pre and post passive leg raise would give you a good indication regarding volume responsiveness in patients who are spontaneously breathing, as well as those who are on controlled ventilation. Next, and most important, would be to look at the chambers, particularly the left ventricle. How is the left ventricular contractility? You don't need to have a precise measurement of the ejection fraction. You need not spend time to measure the left ventricular ejection fraction using the accurate methods that we know that our echocardiographers do by the bedside. Just eyeballing should suffice under most clinical circumstances to look at the overall LV function without having to estimate the precise ejection fraction. Right ventricular size and contractility is another important factor that you would look at, particularly in patients in whom you suspect a pulmonary embolism. There are many patients who might come to you as an emergency who may have hypoxia at baseline with normal lungs, wherein you strongly suspect PE. And in this situation, echocardiography can be a very easy to perform bedside tool. Just eyeballing to look at the ventricle size, the degree of dilatation of the ventricle, and its function. And we're all familiar with the McConnell sign, which is apical sparing when there is right ventricular dilatation in acute pulmonary embolism, although it is not specific for acute pulmonary embolism. So these are some of the features of acute pulmonary embolism by the bedside in a patient in whom you strongly suspect possible pulmonary embolism. They may be immobile, fractured limbs, and in bed, highly susceptible to a clot formation. The next most important thing that you would look for in a patient with shock is, does my patient have a significant pericardial effusion or pericardial tamponade? Very easy to visualize. Basic echocardiographic skills is all you need to look at the collection of fluid around the pericardium, and features of tamponade may be obvious, as in right-sided collapse in diastole. Both the right atrium and the right ventricle may collapse down in diastole, and that is a sure indicator that your patient is at high risk of tamponade or already in tamponade. One of the other things that I strongly suggest that we do is to look for intracardiac shunts in patients with severe hypoxia. For example, a patient with severe ARDS being ventilated with high ventilation pressures, high levels of P, but the hypoxia seems to be very refractory. Whatever you try to do, higher PEEP levels do not seem to reflect as in improvement of the oxygen levels. Is there a foramen ovale that is opened up? Could that be causing a right to left shunt? So the bubble test comes in very handy, extremely easy to do by the bedside, and it gives you conclusive evidence if there is a right to left shunt at all. A right to left shunt in case of an intracardiac shunt will appear within the first 3 cardiac cycles, but if it's because of hepatopulmonary syndrome, it will happen much later, after the first 3 cycles. So that's another important point that you look for when you look at a severely hypoxic patients. So these are briefly the very basic kind of assessment that you do by the bedside in the ICU, focused examination using echocardiography to assess the type of shock, volume responsiveness, look at the valves, see if there is any major change, mitral stenosis, aortic stenosis, all of which can cause severe hemodynamic compromise, size of the chambers, left ventricular size and function, RV size and function, pericardial effusion, and last but not the least, possible intracardiac shunt contributing to severe refractory hypoxemia.
Thank you, sir. I think I've summarized it pretty well. So, as sir said, mainly to differentiate different types of shock, to assess volume responsiveness, for which sir has told that we should use PLR, and to measure aortic VTI and the respiratory swing in the VTI waveform as well in patients who do not have any spontaneous respiratory effort. Apart from that, looking at the LV and the RV contractibility size, and looking at pericardial effusion, and of course, the last thing, the intracardiac shunts. So these are the main things we need to concentrate on when we are looking at cardiac sonography from an intensivist point of view.
Jose, from cardiac ultrasound, we'll move on to the next clinical challenge which all intensivists face, the ARDS challenge. So how does, in a regular bedside practice, ultrasound as a tool helps you in managing an ARDS patient?
Very relevant question, Jaicob. Ultrasonography is in fact a very useful bedside tool among patients with ARDS. It gives you lots of bits and pieces of information which would help you not only to diagnose the problem, but also to guide treatment as well. The way I look at it is, we all know that ARDS is not a uniform disease. It involves both the lungs, of course, but the involvement is not uniform. It is highly non-uniform, particularly with areas of sparing towards the apices, and the bases of the lung are much more involved compared to the apices. The extent of involvement can be readily picked up by bedside ultrasonography. It depends entirely on, one, the number of B lines, the number of B lines per ultrasonographic image, one. Second is whether the B lines are confluent or discretely seen. Confluence means bad, discrete is slightly better. And also, it gives you a good view of the pleura, the degree of pleural thickening and subpleural consolidation, which sometimes even the CT scan may not be able to tell you so much. So it gives you a very good idea about the degree of involvement and also the extent of spread throughout the lung. You can pass your probe from the apex downwards to the bases and look at the areas that are most involved. And there are several scores that have been proposed as well. The aeration score is one of those. The aeration score is based on subpleural consolidation and the number and type of B lines, as in discrete, coalescent, and the degree of subpleural consolidation, and other features of consolidation such as dynamic air bronchograms, tissue lung, and so on. So based on these parameters, aeration scores have been suggested, and I would strongly recommend that you do an aeration score based on this scoring system. It will allow you to follow up your patient with ARDS and actually see if they are getting better over time or getting worse over time. If you do it, say, a couple of times every day, it'll give you a good idea about whether, how much they are progressing in terms of improvement or deterioration. The second most important reason as to why I would use ultrasound in my practice is to look at recruitability. This is a very important question. We use PEEP fairly randomly without really looking at if it is actually going to help the patient or not. recruitment to be effective, the application of PEEP to be effective needs recruitable lungs. If the lungs are not recruitable, regardless of the level of PEEP you apply, it will not reflect as obvious clinical changes. Like, for instance, the ArtsNet group, they suggest application of PEEP based on the FiO2, but that's very empirical. It doesn't take into account recruitability at all. Recruitment maneuvers as such by application of a constant inflation pressure may actually be harmful, as some other studies like the ART trial has shown us. But ultrasonography, you can see with your own eyes. You can directly visualize. If you place the probe particularly in the most involved areas at the lung bases and slowly apply incremental levels of PEEP over a matter of a few minutes, just a matter of few minutes by the bedside, you look at the lungs and see if they're actually opening up. The obvious change will be from, say, dynamic air bronchograms to coalescent B lines. That is progress. It means it is getting recruited. Or it might actually improve from coalescent B lines to discrete B lines. That again indicates recruitability. So based on these findings, you can tell if the lungs are indeed recruitable and whether the application of PEEP will actually improve recruitment, open up more alveoli, and improve the oxygenation and the compliance in your patient. In fact, several preliminary studies have been done in this regard. We are also in the process of doing a trial in this. And so far, from what we have observed, is that it's an extremely useful tool. You know, within a matter of minutes, if the lungs are recruitable and if a higher level of PEEP is going to help or not. So application of PEEP and titration of PEEP based on ultrasound guided recruitability is an important utility of bedside ultrasonography in the patient with ARDS. Third is, many of these patients, as I mentioned, in the initial phase, they may be septic. You may give a lot of fluid, and that might actually contribute to the hypoxia, contribute to fluid-filled lungs, contribute to worsening of the ARDS. And that it may call for the de-resuscitation strategy. As we mentioned, Varghese score is one of those things that you can use. And the other thing that you can obviously use, if you're using diuresis, you start an infusion of furosemide, say 10 or 20 milligrams per hour. Look at the lungs, look at the aeration score at baseline and as you go every few hours. And they can actually tell, based on what you see direct visualization, whether the lungs are actually improving with your diuretic therapy or not. Of course, it will reflect as improved oxygenation as well. You may be able to come down on the ventilation. But here again, ultrasonography is an important tool. So to briefly summarize, it helps you to diagnose ARDS, look at the degree of damage done, extent of involvement of lungs, look at whether there is recruitable lung, and look at the response to treatment in terms of your ventilation parameters, ventilator setting, as well as if you're using a de-resuscitative strategy like with the use of diuretics.
I think a comprehensive coverage about use of ultrasonography in ARDS with regards to helping us in selecting the PEEP recruitment is an option for this particular patient, and also covering how do you proceed with the complications of ARDS and de-resuscitation strategies. Thank you for a good cover.
Thank you, Jaicob.
So finally, a forward-looking question. The role of AI, artificial intelligence, and transforming traditional ultrasound use and its interpretation in critical care. What is the potential of AI to enhance image analysis in diagnostic accuracy and support clinical decision-making? And what could it mean for the future of ultrasound in ICU?
A very relevant question, particularly looking ahead at the future. In fact, I understand there are many machines, I haven't used any of them, that do use AI tools to help assist you with image capture as well as the interpretation of images with ultrasonography and echocardiography. Some of the newer machines do allow that. As I mentioned, I have no experience with those machines. But the future, of course, lies in data analysis, deep learning, machine learning, and big data. Now that's where the future lies, not only in the field of ultrasonography, but with general data capture in intensive care medicine. Like, for instance, if you look at the monitoring trends over time, it has been shown to give you a very good, very precise indication as to which way your patients are heading, which may escape even the most astute clinician by the bedside, simply because we do not have the capability to analyze so much of data in our heads. That's where machine learning, machine analysis would help in a big way. And particularly in terms of the use of echocardiography, there are several tools that have been already employed by some of the new machines in helping you with, as I mentioned, velocity time integral is an important parameter that you go by. Smart VTI and auto VTI, which is automatic measurement of the stroke volume. Once you get a 5-chamber view and once you get Doppler, you don't have to do any calculation. It'll automatically trace a waveform, which even the older machines do. Not only would it trace a waveform, but it'll also give you the VTI straight away without you having to indulge in any calculations in your head. So that is actually, and the cardiac out and the stroke volume as well as a direct measurement. So that will be a very useful tool and can guide you as to whether your probe positioning is appropriate and whether your measurements are dependable or not. So that is good feedback to have as well if you have artificial intelligence at your disposal. And there are several machines which help with, I understand, one-click VTI. If you get the apical 4-chamber view, just by the click of a button, you will get the velocity time integral. So that is indeed extremely useful if you can get a handle on one of those machines. We talked about ejection fraction and eyeballing and the time that it might take for precise measurement of the ventricular dimensions to get a precise measurement of the ejection fraction. All that may be a thing of the past because auto measurements may be possible. It's possible even now. In systole and diastole, you don't need to manually outline the ventricle. It will do it for you in an automated fashion and give you a precise estimate of the ejection fraction, which will go a long way in saving time and also help you with precision measurement of the ejection fraction. Auto assessment of the IVC diameter and its variability in terms of the distensibility index and the collapsibility index, these might also become automated with the newer machines. You won't have to go through multiple steps as in freezing the image, measurement at the maximal and the minimal diameter, and then do your calculation. All those things are going to be a thing of the past. It'll all do it in an automated fashion for you. The other area where artificial intelligence may be of great use is in the assessment of B lines. There is software called Smart B-line assessment, Auto B-line assessment, which helps to count the number of B lines per image, measure the distance between them. So that will give you an indication as to how bad the lungs are, particularly say in ARDS or cardiogenic pulmonary edema. How many B lines, distance between the B lines, are they coalescent or are they discrete? So that will tell you how severe the degree of involvement of the lung is. The other important area of interest with artificial intelligence is to look at the gastric content. We are all worried about patients fasting before major surgical procedures and for other things as well. And automated measurement of the gastric content might again enable you to tell if your patient is adequately fasted in terms of looking at gastric motility, if there is any gastroparesis. So all these things may also be feasible with the use of automated ultrasonography. So it's as in other areas of medical care, AI will play a major role in the future to help us handle ICU, critical situations in the ICU, to diagnose problems, assess progress of our patients with greater precision than we can do on our own, using our own calculations by the bedside.
Thank you, sir. Thank you for beautifully summarizing the role of artificial intelligence, and is something which is quite interesting and something to look forward to in future.
Thank you, Monalisa.
So to conclude, a huge thank you to Dr. Chacko for sharing his expertise and practical tips. I am fortunate to see him using ultrasound as one of his most important clinical tools in daily decision making. His vast experience and thoughtful perspectives reminds us of the importance of using ultrasound, the fifth pillar of a clinical examination, in making informed, patient-centered decisions in critical care. Thank you once again. Stay tuned.
Thank you, Jaicob. Thanks, Monalisa. Till we meet next time.
Thank you for joining us, sir.